Okay, I think we have again gathered back. All participants are present. Okay, yeah. We were looking at how we are going to present stimulus and record the PEM, right? So this is an ipsilateral response, which means when I'm going to present stimulus in this ear, I'm going to record responses from this muscle. Okay, so what do? I will keep the stimulus, the earphone, in the right side, and I will ask the patient to turn towards left side, and I will keep the electrodes here, one, okay, here one, and then two, and then three. Okay, so when we turn, we need to make sure that the muscle is actually visible. So how can we do that? We have many different kinds of patients and with different ages, and everyone will not be similar, and everyone will not follow the same technique. Okay, so we have to modify the way we are asking the patient to stretch this muscle, to put some strength on this muscle. We have two things. One, we can do this with sitting position, and we can do it with the supine position. We can ask the patient to lie down. Okay, the lying down is actually little difficult. We do it in the second part. Okay, we ask the patient to lie down and little bit raise their head. That's it, no turning. Little bit raise their head. Then because this muscle is used in pulling the head, okay, this will be visible. Both the muscles will be visible. Okay, so if supine, we just ask the patient to lift the head a little bit. Okay, little bit, so that we will see them in the EMG monitor that it is falling within the green line. Okay, as regards sitting position, it is little complex and it is easy for the patient. Okay, so we are sitting like this straight. The examiner has to stand in front of the patient and ask the patient to look to them. Okay, so I'm looking at the patient and I will say turn towards left side. I'm recording from the right side, so I will ask the patient to turn towards the left side. Okay, so turn towards the left side. Don't move your shoulders. Don't move your shoulders. Just turn towards like this. Okay, and then what do we do? With this part of the head, try push in front. No, like this. Okay, we have already turned, and this has to maintain, and keep a finger here and ask the patient to push it. Okay, when they try to push, they are going to make a we can see the muscle. Okay, this is second. Okay, we really don't ask a patient to push the finger. If the patient is not turning and moving a little bit, and they don't understand what to do, and they do till here correctly, and they don't do this part, the second part properly, then we will assess the patient by telling, I'm going to keep a finger in your head, and you have to try to push it. So you will try to push the head back, and the patient will try to push your finger back. So you will have a pressure in the muscle, and we will exactly get the sufficient EMG level. Okay. So once we have done that, we are going to have good responses. Okay. So this is the activity which is happening. I said this is an inhibitory response. Okay, inhibitory response means there is a drop in the nerve fired. As we saw in the semicircular canal, that one of the semicircular canal will be excitatory and the other one inhibitory. So when I said inhibitory, it means it always has a spontaneous recording. Everything has a spontaneous recording. Even the muscle has spontaneous a nerve firing. And when it falls below that, it is called as inhibitory response. As you can see here, the spontaneous rate is this, right? And it is falling well below this. You're looking at it. This is the star is your reduction in the nerve responses, nerve firing. Where it is happening at this point. Look at this P13. So the P13 is a very good inhibitory response. And one thing I want you to note is that the P13 is in the opposite direction. This is how it is exactly recorded, and then it is inverted. Okay, and if you don't want this to be like this, we will just change the electrodes. What do we do? So this inhibitory responses is recorded from the belly of the muscle. So when we are going to keep the non-inverting electrode, then we are going to record the first negative and then positive. If you are going to change it, like we are going to keep the non-inverting in the sternum, and we are going to keep the negative in the belly of the muscle, we are going to get first positive and then negative. But most of the literature don't report electrode placements like this. Rather, a standard one is keeping your positive in the belly of the muscle and negative in the sternum. And the software actually inverts the response. So whatever is negative, it changes into positive. Whatever is positive, it changes to negative. Okay, that's how we are getting P1 in the positive direction, N1 in the negative direction. But when we don't do this, we are going to see first negative, and still we will name it as positive 13. And when you're going to have a positive, still we are going to name it as the negative 23. Okay, so I don't want you to get confused that this is your positive and then you mark this as negative. So this is not your response. Rather, this bigger wave is your response. Okay, getting it out. Okay, I think you're speaking about uh, the inverting ones. Okay, I will repeat it. If we are going to record keeping the positive on the belly of the muscle, we are going to get peaks like this. The positive peak in the negative direction and the negative peak in the positive direction. Okay, even if we keep like this, the software, the neuro-audio software, that changes the polarity of the response. So what it does, it inverts the positive and negative so that we get the positive responses in the positive direction. Here, without doing that, we are getting it in the negative direction. And when we do that, we are going to see the positive peak in the positive direction and the negative peak in the negative direction. Is this what you asked? Okay. So once we have recorded two responses from each side to check if they are matching each other. The replicability is good, the reliability is good, and we have recorded both sides. And then the real measure here is to find the VEMP ratio, the asymmetry ratio. Okay. So how do we record it? We use the formula. The amplitude, which means we have our P1 and N1. Okay, that amplitude in microvolt is recorded. With as soon as we mark these peaks, it automatically calculates the microvolt and start displaying it. So this actually is done by a calculator. We have to do it ourselves. So we take the amplitude of the left and we reduce it from the amplitude of the right, and then divided by amplitude of the left and amplitude of the right, and then to get the percentage we multiply it by 100. In the neuro audio, we actually don't need to do these calculations. It automatically shows us without multiplying it by 100. It shows in point. Okay, it shows in decimal point, and it doesn't show in percentage. So this amplitude asymmetry ratio is shown by the software itself, and we don't need to do calculations. But in case if the software is not showing, then we have to do this by ourselves. When there is a asymmetry greater than 30 percentage, then we consider it as clinically significant. Here they have taken it till 47 percentage. Okay, if the responses differ by 47 percentage, they consider it as normal, but it is not the case. Okay, we consider it as 30 only. Any asymmetry, any difference between the ratio, okay, any difference in the ear, if it is 30 percentage and above, we consider this there is a problem. There is an asymmetry, which means one side is good, one side is affected. Okay, so depending on the complaint of the patient, we will know which side has got the lowest responses. depending on the year which we have seen, we are going to record responses. We are going to record the amplitude, right? So we have the responses, we have the amplitude, and we use the calculations, and we get a number. And that number is going to decide if this is normal or this is pathologic. If the number is less than 30%, we say that there is no asymmetry or there is acceptable asymmetry. But when it goes above 30%, we say this is a problem. Okay, this is an asymmetry and that one side of the ear is affected. Is it clear? Okay. So as we said, all these things depend on the asymmetry, right? We are looking at this. Sorry, I think this is not very clear because I took a screenshot and then I have put it here. So you look at the left ear and you look at the right ear. The difference is the left ear has a bigger amplitude when compared to the right side. Okay, if we are going to have an asymmetry ratio calculation done for this waveform, we definitely will say that the asymmetry is greater than 30%, and we are going to diagnose the patient as having some kind of abnormality. But in reality, for this patient, there was no problem. Okay, how do we say that? That's why we start recording the EMG of the muscle, which means before the presentation of the stimulus, we are going to record the muscle activity. If you look at this, so we have two things, which is two channels. So we are concerned about the top one. Okay. If you look at this, without the stimulus only, there is actually the muscle responses here, right? The muscle responses. And then on the right side, we don't have that kind of a contraction. Okay. So the peak is enhanced because this microvolt is added to the response and it is showing a bigger peak. What can we do? We will reduce the EMG from the responses recorded so that the muscle contraction is not a problem. See, how do we get this? Why are we getting this? Because we are contracting a muscle. We are contracting a muscle, so it is going through a potential difference. So that is recorded as the EMG. After contracting the muscle, only we are presenting the stimulus, and then we are checking if there is any change in the muscle response, right? So we have to reduce the pre-stimulus EMG recording, and we have to subtract from the VEMP responses, CVEMP responses recorded, so that the muscle contraction is not a problem. Okay, what do I mean by muscle contraction problem? We are going to start with the right side. So right side, the patient is able to contract very good. They have no problem at all. Okay, but we keep doing it, the patient get tired, and the response for the left side is not good because the patient is not contracting properly. Okay, so it's not a problem with the left ear, it's a problem with the patient's contraction of the muscle. So to avoid all these confusions, we are recording the EMG, and this process is called as rectification. Okay, so what do we do? The first thing is your VEMP responses recorded, and this is your EMG responses recorded, and we subtract these two, and then we will get a rectified VEMP response. So when I say rectification, it means you have corrected the waveform and we have removed the muscle activity from the response. Okay, imagine if a person is contracting too much, the activity is going to be too much. If the patient is not contracting too much, then the activity is going to be less. So depending on the activity, if we reduce the responses from the VEMP wave, we are going to get a waveform which is independent of the contraction. Is it clear what is rectification? Okay. So almost we have come to the clinical application of the VEMP. So the most important application of the VEMP is in the diagnosis of Meniere's disease. What is the Meniere's disease? We have seen this previously when we dealt about the pathologies of the vestibular system. And it's because we don't know exactly why this happens, but the histopathology study says that it is endolymphatic hydrops, increase in the volume of the fluid, endolymph. Okay, so what will it have? What will it do to the saccule? It is going to affect the tuning of the saccule. Okay, so when it has affected the tuning of the saccule, we said that the saccule is tuned to 500 hertz. Now it will no more be tuned to 500 hertz, and the tuning of the saccule changes. Okay, changes to 1 kilohertz. Okay, so what we'll be doing, we are going to record 500 hertz VEMP and we are going to record 1 kilohertz VEMP. If you see that the 500 has got better responses, better amplitude compared to 1 kilohertz, that means this is not a Meniere's disease. If you see a change in the tuning and we are getting 1 kilohertz responses better than the 500 hertz, then this is confirming that there is a Meniere's disease. Okay, and this is also helpful in our glycerol test. The glycerol is used as a confirmatory test. So what do? We provide glycerol, and what does glycerol do is it reduces the effect of endolymphatic hydrops. So it is diuretic, you know, it is actually reducing the volume of the endolymph, trying to bring back the normal state of the cochlea. When we record after providing glycerol, and if we still see that the 500 hertz is better than 1 kilohertz, just like the normal tuning, then that means it is again a confirmation of the Meniere's disease. Okay, when there is an increase in the fluid, we are going to see a change in the tuning from 500 to 1000, and if because of providing glycerol, we are going to see responses, which is we are going to see that the responses are better in the 1 kilohertz. Okay, after we have provided the glycerol test, the status of the cochlea is brought back to normal. So they should be back to 500 hertz tuning. So 500 hertz responses should be better than the 1 kilohertz responses. Okay, I have got it down. Rectification happens in the software itself. So when we try to look at what are the strategies that the system uses to reduce these kinds of difference, we have this biofeedback, which we actually are checking. And then we have the rectification, which is happening in the background. We actually don't do it. It happens by itself. So this rectification for an easy understanding is like your compensated tympanogram. Okay, just like how you remove the compliance of the ear canal to know the compliance of the middle ear, you are reducing your EMG level without before stimulus from the after stimulus response. Okay, so again, if you look at this, the 500 hertz responses is shorter than the 1 kilohertz responses. That says this is a rectified image. Okay, this is your 500 and 1000 hertz EMG levels. Okay, so when the responses are bigger in 1 kilohertz than the 500 hertz, we can say that this is Meniere's disease. Okay, there is again different problem. Okay, the patient will say that they have all these problem like Meniere's, the symptoms will be like Meniere's, but there will not be a difference in the tuning of this cycle. So even after the patient reports of symptoms of the Meniere's disease, but we still see that the 500 hertz is better than the 1 kilohertz, then we will say that this is not a Meniere's disease. Okay, and again, it is not one exactly. We have one type of Meniere's disease. We have combined one. Both your cochlea and the vestibular system is affected, and we have cochlea alone and we have vestibular alone. When we see a difference in the hearing threshold, we see low frequency hearing loss, rising pattern audiometric configuration, but we don't see anything like that with this cycle tuning. There we don't see any change in the cycle tuning. That means that the Meniere's disease, the endolymphatic hydrops, is limited to cochlea only. It is not extended to the vestibular. And we see the opposite. We see a difference in the tuning in the saccule, and we don't see any audiometric difference, no low frequency hearing loss, no rising pattern. Then we will say it is vestibular only limited Meniere's disease, endolymphatic hydrops. Okay, fine. Any doubts in the Meniere's? Okay, if there are no doubts, I will move into the next application, the semicircular canal dehiscence. Again, this is something we have already seen about in the pathologies concerning the vestibular system in the previous class. So this is called as the third window syndrome. So what it does is there is a kind of opening in the bony labyrinth of superior semicircular canal. Because of this, the impedance, the opposition provided by the endolymph is reduced. So what happens? It starts getting more inputs than the normal. Okay, we get enhanced responses. So because of enhanced responses, what happens? As I told you, we do two things. One is we record VEMP with one intensity, and we also record thresholds. So when we record thresholds, we are going to diagnose semicircular canal dehiscence. So what do? We will record at 95, then we will start recording at 85, 75, like that, like how you do threshold estimation in the AVR. And because there is an enhanced response in the saccule because of this third window, we are going to have lower responses or better responses. So for normals, if for example we stop at 80, the thresholds, the VEMP may be present at even 70. Okay, that's how we will say this patient may have semicircular canal dehiscence. Again, the confirmation is not only with this, it's with the imaging techniques. But before going for a costly imaging technique, we need to know if this patient really has the semicircular canal dehiscence. We have to suspect it, then only we send for the imaging. Okay. Okay, then we have its application in vestibular neuronitis or neuritis and vestibular schwannoma. How? Because the vestibular nerve innervation is like this. The posterior semicircular canal and your saccule, the output is sent through the inferior vestibular nerve. And the two other, which is anterior and lateral plus the utricle, is sending its information through the superior part of the vestibular nerve. Okay, so what is vestibular neuronitis? It's a viral infection which affects not exactly the whole eighth nerve. It may also affect a particular nerve. It can only affect the hearing nerve, auditory nerve, or it can affect the superior part of the vestibular nerve or inferior part of the vestibular nerve. So to just pinpoint where exactly is the viral infection localized, we will try to do different tests. Okay, and after doing different tests, if for example the VEMP is normal, the C-VEMP is normal, that means the inferior part of the vestibular nerve is intact. It is not affected by the viral infection. As well as your vestibular schwannoma. Vestibular schwannoma is again a lesion or tumor, right? So if we are going to get responses, C-VEMP responses, and we are very sure that there is no lesion sitting on the inferior vestibular nerve. Okay, so if we don't get, that means we have a problem. So with VEMP alone, we will not be able to diagnose all these things. We are going to have other tests like your ENG, VNG, or we are going to have our VHIT, and we have responses from the OVEMP and CVEMP. With all these things, all these results correlated, we will be able to say that this part is where the lesion is. Again, the diagnosis is not with the vestibular test, it's with the imaging techniques. Viral infection, we cannot do imaging techniques. We are going to find it this way. For vestibular schwannoma or the tumor or lesion, we are going to do an imaging technique to imaging to see if there is a tumor present. Okay. Okay, enhanced response, how? See, enhanced responses because, as I told you previously, I hope you remember that when we do an audiometry, the AC responses will be like in the under normal uh, levels, which is like 10 dB or 5 dB. And because when we are getting like this, we usually don't know do our BC, or even if we do BC, not much carefully, right? So what actually we have to do is we have to go and probe into the BC responses. We have to check if the patient is responding even at minus 10 dB. If it's minus 10 dB and your responses is AC threshold is 10 dB, there is a 20 dB airborne gap, which is suggestive of your SCD, semicircular canal dehiscence. Why? Because your BC responses is better by 20 dB than the AC responses. Okay, so how these responses are better? Because as I told you, we have an oval window and round window. If let's imagine there is no round window at all, if there is no round window at all, then we will not be able to push the oval window much. Okay, just because we are having a yeah. So when we have this round window, it actually accommodates this kind of a pressure change. If we have to check impedance, okay, like if there is no round window, the opposition provided to the force through the oval window will be much. When we have a round window, the opposition is reduced. When we have a third window, when we have another opening in the endonym, we are going to have more sound coming inside because the opposition provided is less. Is it clear? Okay, then we will go into the OVEMP. Any doubts in the CVEMP before we go into the OVEMP? Okay, so the question is there an age range for the VEMP? Can we do it on children? Yes, we can do it on children. There is no problem, provided the child is cooperative. So I think the literature speaks about children from 4 to 5 years of age because they are somewhat cooperative for the testing. What will happen in the VEMP results of vestibular neuritis? See, the VEMP responses, it's not actually, it's just present or absent of the VEMP responses. Let's imagine the viral infection is in the inferior vestibular nerve. In that case, we are not going to get responses, VEMP responses. Okay, then we will say that yes, the vestibular, the inferior vestibular nerve is affected. If we are going to see VEMP present, then we can say that the viral infection is not spread to the inferior vestibular nerve. The same applies with the vestibular schwannoma. Same principle. Yes, it is possible to do it on children, provided they are cooperative. Okay, then the question, muscle behind the neck is, muscle behind the neck is splenius capitis, SC. This is like, you know, your bicep and tricep. So one has to release if one has to contract. This SCM and your SC, okay, they are like opposite muscles. One is in the front, one is in the behind of the neck. Then the other nerves are, yeah, other nerve we have OVEMP, which is coming from the superior vestibular nerve. So to do just with the OVEMP and CVEMP, we can say if the nerve is working or not. Any other doubt? Okay, so again, we have met the 40 minutes time limit. So I will close now. Please join back.